Hi, all, and welcome to Envision's Living in a World of COVID. What is the CHW role in the pandemic now, and what do COVID-19 community conversations look like? I'll start you out today with just some controls for translation. We are offering live interpretation today in Spanish. So to get into the Spanish channel, what you'll want to do is go to the bottom of your Zoom screen, click the interpretation button that looks like a little globe, and then you can choose whether you want English or the Spanish room. If you choose the Spanish room, you can also choose to mute the original audio to just have the interpreter's voice come through. Today, we're also providing closed captioning as an option. You can choose to see the closed captioning by going to the CC Live Transcript button. Select that in your Zoom controls at the bottom of your screen. There also is an option if you're on a phone or a cellular device today. You'll want to go into the controls and then go into meeting settings and view full transcript, and you'll be able to see that subtitle option there as well. That being said, I will hand it over to our facilitator moderator today, Andrea Hayward.
Thank you so much, Courtney. Hello, and welcome to Living in a World of COVID. What is the CHW role in the pandemic now? And what do COVID-19 community conversations look like? The Envision team is excited for today and grateful for the opportunity to once again be in community with you, share this space, and have the opportunity to be working alongside each of you. This month's webinar will shed light on COVID-19 misinformation and what communities that CHW serve are having around the COVID-19 information overload. While on the call today, we have a list of operating agreements to ensure that we can collectively build a welcoming and brave space. Much of today's webinar will be content delivery, so we do ask that you stay on mute and pose questions in the chat box. The chat will function as your primary point of connection today. We encourage you to use it frequently and treat fellow attendees with dignity and respect while doing so. We will have a brief Q&A section at the end of today's presentations. And as a last reminder, to do what you need to take care of yourself. So on to our agenda. Today, I'll start with sharing some exciting Envision news, including the launch of our new website, an introduction of new staff members, and the timeline for CHW Council applications. After Envision updates, we will dive into our primary content. This will include 3 presentations on the current state of COVID-19 and how CHW programs are continuing to engage with COVID-19 and promote community well-being. But first, going on to tell you a little bit about who we are. The Envision Equitable Healthy Communities CHW Training Center is composed of CHWs and CHW allies who work together with financial and administrative support from the Centers for Disease Control and Prevention to elevate the role of CHWs in COVID response and recovery. Envision supports the CDC-funded program, CHWs for COVID Response and Resilient Communities, which uses the acronym CCR. You can find details about the initiative and who the funded organizations are at the link in the chat. So we'll tell you a little bit more about how you can learn more about Envision and our team by sharing this very exciting news that our Envision website is now live. We have officially transitioned from a landing page format to a fully functioning website. This includes resources for CHWs, recordings of prior webinars, and more information about the Envision team. And with that, we are absolutely thrilled to introduce you to the new Envision staff team members. If you are here and can come off mute, please provide a short introduction, including your name, role, and where you're located.
Mungshi, why don't we have you start?
Yes, I could go first. Hello, everyone. My name is Mungshi Kang. I am located in Wisconsin, but specifically in central Wisconsin, Wood County. And I am the new CHW training coordinator. So thank you all.
Hello all, I am Monique Allen. I am located in the high desert in California, and my role is the community of practice lead. Nice to meet everyone.
Hi there, my name is Sarah Elise Bristol. My first name is Sarah Elise, and I will be the Community of Transformation Lead. I'm coming at you today from Bellevue, Nebraska. Really happy to be here. Thanks, everyone.
And I believe Lynette Walker is on.
Hello, everybody. This is Lynette Walker. I'm coming to you from Wisconsin, central Wisconsin, and I am going to be the CHW program consultant. Thank you.
And our new evaluators. I don't believe our new evaluators are on the call today. So Kelsey and Kira joined us in August as well, and they're coming out of New Orleans, Louisiana State University.
Awesome. Thank you, Sherry, and thank you all for those introductions. We're so excited to have you join the Envision team. Finally, we have news on the Envision Council nomination process. The nominations have just closed, but just to highlight some upcoming dates, for those who have been nominated, applications are due by November 15th, 2022. We anticipate the selection of new council members by November 30th, 2022, and hope to notify council members by November 30th and on board between December 1st and 14th of 2022. With that, it is my pleasure to transition into the primary content for today's meeting, the state of COVID-19 and CHW community conversations. This section will be led by Malia Jones, Assistant Professor of Community and Environmental Sociology at the University of Wisconsin, and co-founder and editor-in-chief of Dear Pandemic.
Thank you so much for having me. It is a real pleasure to be here today. I am going to talk today about kind of an overview of where we are with the pandemic. I am a demographer and a health geographer at the UW-Madison. And what I do is study health disparities and vaccine hesitancy. I've been doing this for long before the COVID-19 pandemic, and now my work focuses a great deal on COVID-19 vaccine hesitancy. Next slide, please. So I'll give you a little outline of where we're going. First, I'm going to talk about where we are now in the pandemic. I'm going to talk briefly about when a pandemic ends, and then I'm going to talk to the extent that I can about where I think we're headed next, understanding that it's always hard to predict the future, and never more so than during an uncertain time like the pandemic. Next slide. So first, a little bit about the current state of the pandemic. I think at the moment there's a lot of confusion about whether the pandemic is over, whether the pandemic is still happening, when will it end, and so forth. Next slide. This is a graph that shows the number of COVID-19 deaths per day. And I pulled this for the state of Wisconsin. It looks fairly similar for most of the other states in the country and the country overall. And you can see that we are ticking along at this time in late September into October. And it's been pretty steady in terms of the number of deaths per day since around April, which is when the Omicron wave that hit us in January really started to leave off. Next slide. The number of cases per day, again, has stayed pretty level. But if you were to look at those graphs side by side, you'd notice that the number of cases and the number of deaths don't really look exactly alike. And I think what is happening here, one of the important features of the pandemic right now, is that almost everywhere in the United States, all prevention measures except vaccination efforts have ended. And so we are seeing a lot of community transmission of COVID-19, but we're really not detecting it because nobody is testing in the same way that they were testing back in January of this year, for example. So we are still seeing continued cases, and that really does show up in the death rates, but we are not seeing as many cases in the statistics because we're not testing anyone. So one of the things that we're really sure about during the pandemic right now is that our case detection systems are quite wrong. Next slide. One way we can really see this is by looking at wastewater data. A number of sites, mostly in urban areas around the country, are testing wastewater, or the water that leaves our homes, for COVID-19 virus. And you can see that we have had, this graph is a little hard to read, but if you look at the red and orange sections towards the bottom of the graph, that shows red and orange show the places where we're wastewater testing that have seen an increase in cases since the previous week. And so you're seeing a pretty sustained number of places that have an increase in cases since the week before. And that goes all the way back to mid-February. I think this really does highlight that the case numbers that we see come out in the news and from the CDC are not capturing all of the cases that are circulating right now. There are very few places that have a large decrease in cases over the previous week. Next slide, please. So that is, I think, one of the main current challenges that we face with the pandemic, where it is right now. There is really no systematic tracking of the number of cases, which makes it very difficult to know what we're dealing with. We have some other major challenges, however. One of them is that we have continued vaccine hesitancy in many parts of the United States and many subpopulations. When we look at the vaccine rates for children, we see really strikingly low uptake of COVID-19 vaccinations. We've also seen very low uptake of booster vaccines, and that's across all populations, including those who are at high risk because of their age. We also still have a lot of outstanding questions about long COVID, including what causes it, why some people get it and other people do not, how common it really is, how long it lasts and how it impacts our lives, and how to treat it. And that's a situation that is going to affect public health for, I think, a long time into the future. As I see it, another major challenge we're facing now is that in some settings, we treat COVID-19 really differently than in other settings, and that is exacerbating structural inequalities. And I'll just give you an example. I'm in Madison, Wisconsin, and in our school district, I have 2 children, and there are no prevention measures in the schools. No one is required to wear a mask or get vaccinated or social distance or really anything. However, if your child gets COVID-19, they cannot return to school for 10 whole days. And when this happened to us in early September, I was really struck by how lucky I am to have a partner who works from home. If I had to have my children home for 10 whole days and be a single parent, that would have been a really serious financial crisis for our family. And I think this unequal treatment of COVID-19 and the lapse of any kind of prevention is still exacerbating structural inequalities. We also have zero continued support for being flexible about things like wearing masks. And this worries me because, as I'll talk about in a minute, we could see new variants that are more deadly or even easier to transmit than previous variants. And in a situation where no one is willing to wear a mask under any circumstances, this is a real challenge. Next slide, please. So when do we get to the end of a pandemic? Next slide. Not too long ago, President Biden on the news program CBS's 60 Minutes declared that the pandemic is over. And there was a lot of reaction to this declaration because he was incorrect. The President of the United States does not get to decide when a pandemic ends. If you can click to the next part of this. In fact, the folks who get to decide when a pandemic ends are authorities at the World Health Organization. World Health Organization is a global cooperative of public health officials and policymakers. World Health Organization decides when a pandemic begins, and they also decide when a pandemic ends. And it's really important to understand that the pandemic is officially not over, which is actually quite a helpful situation, because when there is an public health emergency, like a pandemic, a whole suite of international policies comes into effect. And these are the policies that are allowing us to, for example, share vaccines with other countries. It's very important for global public health that the pandemic is not officially over yet. So even though we're all over it and very tired of living with a pandemic, I think it's important to understand that it's still a major global public health problem. And the reason it's not officially over is to support people in lower resourced countries. Next slide. The other point that I wanted to make in this section is addressing everyone's frustration, and I know it applies to many of you, about why the guidelines keep changing. And I wanted to talk about this because there are good reasons why these guidelines, like do we wear masks or not wear masks? Do we get a booster or are we not eligible yet? They keep changing because the science itself keeps changing. Science is not a set of facts. It's actually a method. And the information we have is always changing about COVID-19. And so one of the reasons the guidelines have changed continuously, and it really does seem like it's a moving target, is because actually our understanding has evolved and will continue to do so. In addition to that, the situation itself keeps changing. We have gone through phases. For example, earlier this year when Omicron was just everywhere, when the situation was really very different as compared to over the summer as cases dropped off a little bit. And I just want to tell you that unfortunately, both of these things, both the science and the situation, will keep changing for a while yet. this is still a really dynamic situation. And so I think we can expect more changes to guidelines. I will say that at this point, we are looking at one of the goals is to figure out how to live with COVID-19 long-term. And so one of the goals with the guidance, especially coming from the CDC, I think, is to streamline the guidance we have and make it a little bit easier to understand. So for example, I fully expect that COVID-19 vaccines will become annual and that we will likely be recommended to get them every fall, starting next fall. And that's probably why CDC said that all people who are eligible for vaccination should get the updated booster this fall. Next slide. So where are we headed next? People ask me to predict the future a lot these days, and I will do my best to talk a little bit sensibly about what I think is coming. Next slide. We will have more COVID-19 variants. Right now, the predominant variants in the United States are all daughters of Omicron. So the Omicron variant was pretty different from ones that preceded it. And it continues to mutate, and we're still facing a lot of spin-offs from Omicron variant. However, that does not mean Omicron will be the last variant. In fact, I would be very surprised if it is. Next slide. Nathan Grubach is an epidemiologist at Yale University. And back when we were facing Omicron, he said Delta was never going to be the last variant, and Omicron is not going to be the last one. As long as there is a COVID-19 outbreak somewhere in the world, there is going to be something new that emerges. So we will be facing more variants in the future. And as I said, one of the things that really concerns me about the current situation is that we really have no flexibility to increase our protections except through promoting vaccinations. Nobody is really willing to do social distancing or mask wearing at this point. And so if we have a variant that is more lethal, I think we could be in real trouble from that. Next slide, please. So what is our goal right now? Our goal is to try and decouple the number of deaths and the number of cases. Since the pandemic started back in March of 2020, the United States has seen more deaths by up to 50% more than we see in a typical year, except for one little blip back around last fall, around this time last fall, when the number of deaths dipped slightly below normal for a little while. So we have been living in a situation where the total number of deaths is higher than normal for 2.5 years now. And it really is our goal to try and get the number of deaths down, even if we can't get rid of COVID forever. How do we do that? Our best shot at this is really through vaccinations. Vaccines offer excellent protection against death from COVID-19, even if you get COVID-19. So vaccines and boosters, especially for older people, are essential. And vaccines and boosters are really important for children as well, because they do, in many cases, reduce the duration of COVID-19 or prevent it completely. And every kid who doesn't have COVID-19 is not spreading it to one of their vulnerable grandparents. I think we can still think about efforts that go beyond vaccines. I am still encouraging people to strategically test themselves. For example, we have the holidays coming up. It's a reasonable thing to test yourself and your family before you go see vulnerable older adults. We can also mask sometimes. The way I think about this is I don't need to get COVID-19 from strangers. I do still wear a mask when I'm on the bus. I do not wear a mask in most other situations. Next slide. So how essential are vaccinations for preventing death, even if you get COVID-19? Death rates for unvaccinated Americans are 8 to 10 times higher compared to vaccinated people of the same age. It's a huge difference. I also want to highlight that we can do better than fully vaccinated because we do have boosters. Fully vaccinated, just the 2 initial shots, is not fully protected. There is a difference in death rates between people who've just had their first 2 vaccine shots and people who have also had 1 or 2 booster shots. Next slide. And when we look at how vaccine uptake and booster uptake are going, there's really a lot of work still to be done. Booster uptake in particular is very poor, even among the most vulnerable groups. So you can see these data from Wisconsin show that about half of Wisconsinites between ages 55 and 64 have received a booster. Only about 18% of Black Wisconsinites have received a booster. So we have a lot of work to do getting the number of deaths down for the number, and we can do that through promoting booster uptake. Next slide. Protecting kids with vaccination is also really important. As I said, protecting kids, I think, is valuable on its own. We do see clear differences in the severity of disease for kids who have been vaccinated, even kids who've had COVID before. And although we have pretty good, or at least similar coverage for older kids, kids who are between 12 and 17, over 60% of kids between ages 5 and 11 are not vaccinated nationally, and over 90% of kids who are between 6 months and 4 years have not been vaccinated at all in the United States. Next slide. As I said at the beginning, I think one of our upcoming challenges is long COVID. This could become a major national public health issue. Estimates show that between 2 and 10% of adults who survive COVID-19 have symptoms, often debilitating symptoms, that continue for more than a month. We really don't know what the long run course of long COVID is. We don't know how long it takes to recover. And if we just take 2 to 10% of all adults in the United States, that's between 4.1 and 21 million people. And I know that's a big number. Big numbers are hard to understand. So next slide. I just wanted to put this in context. 21 million adults is the number of adults in the entire state of Texas. And 4 million adults down at the low end is all the adults in the whole state of South Carolina. So we are talking about a lot of people who have long COVID. Next slide. I do think that the changes to guidance will continue, but that the pace of change is slowing. I expect we'll be seeing some new things coming about who needs boosters and when. As I said, I think we'll go to a situation where we are all recommended to receive an annual booster shot for COVID-19. Next slide. And I don't want to end my talk here without mentioning that COVID-19 is not the only public health issue we're facing. Flu season has just begun, and early reports on flu season this year say that it is going to be a bad one. Next slide. This early CDC report that came out last week explains that we expect a bad flu season, in part because a lot of young children have never had a flu exposure or been vaccinated. In normal times, many young kids get flu or have a flu exposure every year. But during COVID, a lot of COVID babies have never had flu before. We have also seen drops in flu vaccine coverage in the past 2 years among high-risk people, including children and pregnant people. So we are really worried about a terrible flu season this year. Flu shots are available, and if you're out there in the community and it seems too hard to talk about COVID-19 vaccines, I think it would be a great way to open a conversation about vaccines to recommend flu vaccines because they really are necessary. Many people are more open to flu vaccines than COVID-19. Next slide. On top of flu, we also have thousands and thousands of children in the United States who've fallen behind on their other vaccines. And this graph is showing for the state of Wisconsin, for the whole duration of the pandemic, we have seen kids at up to 80% lower than normal vaccine doses given. And it's really concerning that in the more recent months shown on this slide up to June 2022, those rates are actually still falling. So we're very concerned about, in terms of vaccine hesitancy and public health as a whole, about catching these kids up on their regular childhood vaccines. So again, if you're out there in the community, this is a great opportunity to introduce the conversation of vaccines without having to touch that hot button topic of COVID-19 vaccines first. Next slide. So that is my account of where we're at with the pandemic right now. If you want to check out our science communication project, our website, thosenertygirls.org, is right there, and you're also welcome to email me.
Thank you so much, Malia. Such great information, and a reminder that we will have a Q&A after all of the presenters have brought forth their information. We will now transition to Justin Duncan, who will highlight his experience as the CEO of CCR 2109 recipient, Washington County Ambulance District.
Good afternoon, everyone, and thank you, Andrea, for the introduction. And Dr. Jones set me up pretty well perfect, so we're going to go ahead and tee off here. It's nice to sit in a room of folks and hear what's happening across the country, and it makes you feel a little less crazy. Next slide, please. So I wear a few hats. I serve as the CEO for Washington County Ambulance District. We are a regional mobile healthcare authority. We are in Missouri, and I'll drop a little bit of a map here. I also serve as our state's EMS association, and I chair the statewide committee for this little project we call Mobile Integrated Healthcare. Next slide. Our primary service area is 762 square miles. Very rural. I tell folks we have more cedar trees than human beings. We have a population of about 25,000 with a very low socioeconomic landscape and big issues with health literacy. When we look at our regional system, we have about 1,500 square miles, primarily rural, and we dip into some urban and suburban areas. Next slide. For the purpose of this discussion, and the project that we're a part of, we're going to talk rural. My heart's in rural, and as you can see, my home county, as I call the flagship, we're about an hour south of the St. Louis metro area, and my other service areas are even further south from there. So the rural perspective it brings unique and interesting challenges, and that's how we came to develop this thing called Mobile Integrated Healthcare. And I hope the translators can pick up on sarcasm, but in Missouri, the pandemic ended about 18 months ago. That's what we were told anyway. But the people who take care of sick people would argue that fact. Next slide. So mobile integrated healthcare and our model is really exactly what it sounds like. We accept that there's healthcare that takes place within brick and mortar and outside of brick and mortar, and we primarily take care of the patient outside of brick and mortar and link them into the clinic. Our model utilizes community paramedics and community health workers to care for patients in their home. So we not only have community health workers back in the clinic doing care coordination and navigation, but we also have community paramedics who are dual certified as community health workers in the patient's home, in their living rooms, at the churches, in the schools, out in the community. Next slide. Our goals of the program high level are very, very simple. When we started this project, we accepted that we have lots of sick people and they don't manage their conditions very well. They utilize emergency departments for their primary care providers. They utilize my folks for their primary care providers. And how can we bridge that gap? When the global pandemic hit, we simply took that model and that mindset and applied it to the response to COVID. Next slide. Now it's grown over the last couple of years, but in the early beginning, we all sat in a room. And in rural Missouri, much like many rural areas across the country, all of our services that care for sick people are small and understaffed. My public health department has 2 nurses. I have an FQHC in my community with limited staff. We have a critical access hospital. I'm an ambulance service that covers a massive area with a staff of 50 folks in Washington County. That's full-time and part-time. So we came together and said we were going to work through everything together. And that started with swabbing, monoclonals, in-home vaccinations. We've been doing in-home flu vaccinations for about 20 of the years that I've been doing this. So we just added COVID to that mix. And then as we progressed, we found that folks were nervous. They didn't know what to do. So we started doing wellness checks and in-home assessments of the patient just to help guide them through their disease process. And while many of the times we were there for COVID, we wound up explaining to folks that just because you're in COVID quarantine, your diabetes didn't get better. Your heart disease didn't get better. We still have to manage your chronic conditions, and we'll help coordinate with your primary provider and facilitate telehealth visits, do in-home lab draws, and make sure that folks got their medicines, because those chronic disease conditions, they still had to be managed regardless of the pandemic. Next slide. So as we progressed, we kind of came down to 4 high-level goals. 1, we wanted to identify and quarantine, identify and educate. So we ensured rapid swabbing was available 5 days a week and without question. It started in a drive-through style, so folks didn't have to get out of their vehicles and they didn't have to come into clinic, because we didn't want them to potentially come into a well space, and we wanted to be able to isolate them. Well, my business takes care of folks on the side of the highway or in their living rooms. So we applied good public health work and went at it from an EMS paramedic mindset. So then monoclonals came to fruition, and we were able to identify COVID positive patients and then arrange for, in the moment, monoclonals, be it at an outpatient clinic setting or in the patient's living room. As you can see the photo here, yours truly, we were scraping the bottom of the barrel, and I had to pretend to be a paramedic for a day and dust the cobwebs off of my license. We're doing an in-home infusion on the COO of our FQHC at her dining room table. The mentality that we took there is, we have infusion clinics in our communities, but they're inside our hospital, they're inside our clinics. And do we want to bring a COVID positive patient and march them through the front doors? Absolutely not. We took a dental clinic, a mobile dental clinic that used to go out to schools and do dental visits, and we parked it in a parking lot and turned it into our COVID clinic for folks that didn't want us coming to their home, but that we didn't want to go to facilities. Wellness checks were goal number 4, and our public health department was our primary referral source. In the times of contact tracing, every COVID positive patient was referred to our MIH program for follow-up. And that follow-up was, can we come and check on you? If you're positive, please don't load up your entire family and bring them to the doctor's office. We'll come swab you in your home. Do you need treatment? how are you doing? Do we need to do spot O2 checks? And then navigation of when is it time to go to the hospital and when is it time to stay home, and coordinating that care with the primary providers. And of course, getting shots in arms. As Dr. Jones said, we have vaccine hesitancy across our country, and our community is no different. We have massive vaccine hesitancy, and our message has adjusted over the years. When we first started, that's when you saw the heroes work here everywhere, right? And now we've shifted, unfortunately, fast forward a few years to, well, you can't tell me what to do. So we've really had to adjust our message and work with folks that are vaccine hesitant. And I will say we've made some progress, but not nearly enough. Next slide. We also had been trending on an internal basis. So this was going to be a spread of 2 years. The Q4, as you see, at 36.5% positive rate, that closed on August of 2022. So this past August, we still were showing a 36.5% positivity rate. But to echo Dr. Jones, we are not seeing nearly the volume because COVID isn't cool anymore. And quite simply, folks don't care, or they don't have the ability to test positive when you have those honest conversations because they have kids. What do I do with my kids? I can't miss any more work. I'm going to lose my job. How am I going to keep a roof over my head? So folks, quite simply, they're not getting tested. The volumes have decreased, even with making it as easy as possible. Next slide. Our path to making a difference was shots in arms. And this was in the days, the early vaccine days. We gave 18,000 vaccines in 2020. This is my building, my primary building. This is a garage that usually houses ambulances. You usually see one in that back corner is a mechanic's bay. And we cleared it out and we've turned it into drive-through clinics. And folks said, how did you get so many shots in arms? And we said, we've been doing this style for flu vaccines for years and years and years. We just flipped the model to COVID vaccines. It was a little more paperwork, and it happened to be that we kicked off on the snowiest and iciest weekend in years and years and years in our community. But we put 18,000 shots in arms in a year. That was through drive-through clinics. That was in people's living rooms. That was in church parking lots. That was in bank parking lots. That was all over the place. But a massive amount of vaccine for a small community. Next slide, please. What I see here is diversity, and this was our first vaccine clinic. And just to point out the level of diversity that we have, you have everything from public health nurses. We closed down the county courthouse to get helps with registration and documentation. You see paramedic students, you see EMT students, you see nurses, you see NPs, you see licensed paramedics, all there for the same common good, to throw shots in arms. Next slide. Of course, as we advanced, you will now see stacked PPE in the back corner there, and the same folks showing up in multiple layers of cold wear. Again, shots in arms, trying to slow the spread and reduce mortality. Next slide. That's just an outside graphic of one of our clinics there with folks nonstop coming through. Next slide. So messaging, we talked, we're anticipating a scary flu season. We went backwards and went, well, why are we only doing COVID vaccines? Let's just do all of the above. So our messaging now going forward is flu and COVID. We're doing clinics. We did an adult 65 and older, trying to cater to the most vulnerable population. We set up after hours clinics, trying to make it as easy as possible for folks and to reduce the ability to have excuses. Next slide. Taking the shots to where you're going to catch people. So we identified very early on, again, our model was outside of brick and mortar, not just inside brick and mortar. Well, outside brick and mortar doesn't need to just be at the ambulance base. Why not in a church parking lot that happens to be across the bank parking lot that just happens to be across from a really big church in the community, and we'll time it so that when folks are getting right out of church, they can't miss us. Next slide. And we're offering flu shots, but we're offering COVID vaccines as well. Do you need your COVID-1? Do you need your COVID-2? Are you due for a booster? We can address all of those things in one fell swoop and make it as simple and easy as possible. And then from the engagement standpoint, you see LPN students here who are getting massive patient contacts and interactions with community members, learning how to provide education, learning how to interact with community health workers, and engage in folks to get shots in arms. Next slide. Our mobile unit, as we discussed, was bringing the vaccines to the patient. So we have a refrigerator so that we can appropriately transport those vaccines. And in the picture on the right, that's rural Washington County, and swabbing folks in their living room to reduce the spread, offering vaccinations and spot checks in the moment. Next slide. We're talking about our community health workers and battling COVID. And of course, we want to address all of their medical needs. But we, in the moment, decided that we were going to address all of their needs, not just clinical, but non-clinical as well. So if you're trapped in your home because you have COVID, do you have access to food? Are you appropriately sheltered? How are your medication stocks? Do you need help interpreting these at-home swab kits? One thing that we learned early on was that we have folks that weren't able to follow the instructions, and that we still have folks that don't have the ability or don't know how to read. So instead of handing them a swab kit and saying, figure it out, we would sit in their living room, swab them, walk through the process, and then go, okay, now you do it, and let's swab your spouse or swab your child to ensure that they knew how to do so. Next slide. Our team last year did 7,000 touch points. Most of it was, not most of it, a good chunk of it was related to COVID work, but there was COVID education provided in every one of those encounters. So if we were in someone's living room talking about diabetes and managing their diabetes, we would ask them about their vaccination status. Are you vaccinated? Are you due for your booster? Can we go ahead and schedule that for you? And we're still doing vaccines outside of a surge and outside of clinic every single week. Every Thursday is dedicated to vaccines in our community, and not just COVID, flu, shingles, pneumonia, Hep A, walking through the residential care facilities, offering it to the jails, offering it to support our local prison. Anybody who will listen to us, pretty much, we offer the ability to provide education on prevention, education on identification, and then treatment, and of course, vaccines. Next slide. So we had some lessons learned, and I'm going to turn it and call them success stories, but our overarching mission is to ensure the right care at the right place at the right time. Next slide. And when we talk about what we think are our success stories with our CHW team and our community paramedic team and our local network, it's that to this day, we're still swabbing folks 5 days a week. Even though we were told over a year ago that the pandemic's over and you don't have to do that anymore, we said as a community, we want to have that service available. We're not going to push it. We're not going to demand, but we're going to offer. And I will tell you, there's days that 2 people come through the line, and there's days that 50 people come through the line. And we have pushed through advertising and quite simply word of mouth that you can't come to us, we'll come to you. Is there any way that we can narrow down the excuses of, well, I don't have transportation? Well, great, we can come to you. I don't get off work in time to make it to the public health department. Awesome, we're here 24 hours a day, 7 days a week. I don't have access to transportation. Great, we can come to you. Next slide. As I said, any reason to talk about COVID, we took the opportunity and we take the opportunity. So if we're in someone's living room for a lab draw, we ask those COVID questions and we offer those COVID services. A telehealth visit for your diabetes. Let's talk about COVID and when you're due for your booster shot. We're sitting at a health fair. We offer COVID. We sat at our county fair and offered COVID vaccinations. Of course, after hours, and always throwing in, we'll come to you. Next slide, please. Home tests, as I said, had lessons learned on literacy and ability to use them, but then also there was not methodology for reporting. And so we had developed a website with a QR code that made it extremely simple to ask folks to report. And then that went to a database so that we could follow up with them, so that our community health worker team and our public health team could call and say, all right, Mrs. Smith, looks like you swabbed positive. How many folks are in your household? Do you need us to come and swab them? Do you need any more kits? How are you feeling? Can we send a paramedic team out to do a spot check? Let's walk through the inclusion criteria for a monoclonal. Let's see if you meet criteria. Oh, you meet criteria? Well, let us help arrange that monoclonal for you. Who's your primary physician? Oh, you don't have a primary physician? We can make sure that you have a medical home. And at least in the moment, we can get a telehealth visit with a provider and walk through the inclusion criteria. And then once they sign off on it, we'll go ahead and schedule you for your monoclonal infusion and hopefully get you feeling better. High touch, not pushing, but offering and making it as easy as possible. Next slide. In our first cohort, we studied 500 monoclonal infusions, and this was during the Omicron surge when our local hospitals and hospitals in our state and region were surging, and we were housing critically ill patients in critical access hospitals and in community hospitals. And to be quite frank, there were no ICU beds for these folks, and they died. We had people that were dying in rural communities every single day. We had staff that was overwhelmed. And, you know, there was a group of us that said, we can build all of this equipment, you can build these structures, but you have to have human beings to take care of sick people with the experience and the knowledge base to take care of these very critically ill folks. So we took it, since our reactive approach wasn't working and we were literally bursting at the seams, and we said, okay, we really have to work on the front end with making sure folks and preventing them from getting COVID if possible. And it wasn't just lack of ICU beds for COVID. There just weren't ICU beds for anybody at a very poor timing. And so folks had negative outcomes. In our first cohort of 500 monoclonals, they were all triaged as high risk. There was one death in that cohort. That patient presented with severe COVID, and it was identified early on that he likely wouldn't fare well. But the 499 others, 0 presented to the emergency department and 0 were hospital admissions. So we consider that a huge success story, that by definition, all of those folks would have been inpatient. That's why they met criteria for the monoclonals, and we were able to keep them out of the hospital. Next slide. As I stated, of course, the public health referral process has always been there, but it really ramped up during the surge, and they were on board with helping us get to folks before they got sick. And really, from a business that I historically belonged to, reactive, we really switched our approach to a full proactive, but then also back end. So we'll get you through COVID, but then we want to tag you in a communication and a face-to-face or a phone call on, all right, you're at that magic timeline. Are you now ready for your vaccine? Next slide, please. This is just an example of the letter that was provided with the services, and that can be dropped into the chat, of ideas of resource to just offer it to your community. And again, not forcing it, but we're here when you're ready. Next slide. We made it as easy as possible through social media platforms, through good old-fashioned radio campaigns, which are still popular in our community, and local papers. And there was no competition. I think that's something that is a success story. Nobody cared or cares where that shot comes from, right? As long as we get vaccine in arm, we're all happy. Next slide. This one kind of starts to where we're at today, and that's bringing on those personal stories and driving it home and talking about long-term complications and talking about death, having very honest conversations with the overall marching mindset of we're here to offer, we're not passing judgment, we're simply here when you're ready. Next slide. So this was a graphic that was pulled a couple of days ago because we met as a group, and really Dr. Jones inspired me to kind of change up my presentation a little bit. And this graphic should make most people go, wow. And looking at the death rates of my county versus rural Missouri versus the state and versus the country. I mean, you're talking about a death rate that is nearly double what the rest of the United States is. And so with a population of 25,000, the cursing and the blessing of a small community is that everybody knows everybody. So we have taken the opportunity to use death and permanent disability and long-term complications to have honest conversations with folks, because everybody knows somebody. They know somebody who died. They know somebody who still has permanent disability. They know somebody who will never be able to work again. They know the 30-year-old firefighter who he recovered, but now is having recurrent strokes and will never be able to work again. Or the 23-year-old who was had severe COVID and died before he could ever get to an intensive care unit and in an inpatient setting, or the preacher at the Methodist church who was on a ventilator and was trached for 6 months, and it took about 2 years for him to stand behind the pulpit again. So we took the opportunity, and we still take the opportunity, to have these honest, very serious conversations. And I think that's the value of the community health worker, and marrying them with our community paramedics, and our community paramedics becoming community health workers, because these are folks that grew up in their community, they relate to their community, we're a part of the community, we live there, we see that, we're one of them, and just having an honest conversation. Next slide. We, of course, did our internal trends, and I think this graphic just really helps to drive home our death rates in our community, and just to take what we're tracking at the local level and comparing it to national data sets. Next slide. I want to thank all of you for the time and understanding a little bit about the rural communities and the resource deserts. They're there, whether you're rural or whether you're urban. The desert just looks a little different. So I implore you to think outside the box and have those honest conversations and take care of the patients. Thank you.
Thank you so much, Justin. What great information. And again, I'll just remind everyone that we will be having a question and answer session after our next presentation. I have the pleasure of introducing Justin Rahman and Rosa Serrano, who work for another CCR 2109 recipient, the Harris County Public Health in Texas.
Hi, everybody. Nice to be here with you today. And Justin, I love your name, and I love the model that you just explained. And yeah, hopefully we can add to that here for everybody as well. So as we were introduced, my name is Justin Rahman. I work here at Harris County Public Health, which services the city of Houston and beyond, as we are Harris County encompasses the city of Houston. And it's my pleasure to also introduce y'all to Rosa. a community health worker with us and a team lead as well. So Rosa, if you want to introduce yourself.
Hi, good afternoon, everyone. It's a pleasure to be here as well. Like my colleague said, Mr. Roman, my name is Rosa Serrano. I've been working with Harris County Public Health for over 2.5 years now. I am a resource navigator, a community health worker, and also a team lead.
So today we're going to kind of share with you the landscape of Harris County, some of the work that we do with our community health worker team, and some of the tactics that we use to really navigate the conversation of where we are today, as has been explained, and everybody here really understands people are over COVID, but we can't. We have to lead the way in terms of being a county health department and our community health workers and keeping that conversation going.
That's why I couldn't have said that Shayna, because he had already had.
So we can move to the next slide. So quite a different community here in Harris County. We are huge and diverse. It is the third most populous county in the United States. Over 4.7 million people served by our county health department, and really multiple different types of communities and populations all throughout Harris County, which we can take a look at the next slide. So before we look at the map, Harris County Public Health, as the county health department, we are serving those most underserved throughout our county. We provide comprehensive health services and programs from violence prevention to mosquito vector control, to creating access to healthcare services and public health. And we're really focused on the social determinants of health and have an equity lens in everything that we do. So really trying to improve the overall health and well-being of our residents in which they live, learn, work, worship, and play. There is a little interesting dynamic with us because we also have a Houston Health Department. So if you're wondering why we're saying 2.3 million people here, is because outside of the city of Houston, that is really our focus, to make sure that the unincorporated parts of Harris County are served, and those unincorporated areas of Harris County contain 2.3 million people. And as I mentioned, we're responding to various public health concerns and emergencies, and COVID-19 is definitely one of the main ones that we're working on right now. So on the next slide, we'll actually, this time, take a look at our county map. And so we are broken up within 4 precincts. Each of the precincts has a commissioner, and then we have a county judge that govern the county. So you can see how big our county is here. And then also, within the city of Houston, you have your urban and metropolitan populations. And as you go to the outskirts of Harris County, you get more and more rural, as we have all kinds of different languages and ethnicities that we serve. So it's really important that we, as Harris County Public Health, employ and make sure we have a very diverse group of community health workers to represent the voices that we have in the community. And so along with the vaccine hesitancy that we see overall, one of the challenges in Harris County is that there's so many different types of populations. So there's a lot of different mechanisms that we use to make sure that we're targeting the populations. And Rosa will talk about that a little bit later as well, in terms of how we make sure to target specific populations and address the concerns that they have and bring information to them in a meaningful way. But just wanted to highlight not just the size of Harris County, but also the different pockets of Harris County that really create the work that we do and make it a little bit challenging, but we want to share some tips on how we address those challenges. So next slide. So just to kind of sum that up, so we have 4.7 million plus people being served in Harris County, 145 languages spoken. You can see kind of the breakdown of the race and ethnicity as well. And then we really like to highlight this percentage of linguistic isolation. So that's nearly 12% of our county that lives in linguistic isolation. So we have to make sure that our resources, all of the information that we're sharing is shared in multiple languages, so that those that are living in linguistic isolation and cannot understand English still has access to that information and that it reaches them in a meaningful way. So just wanted to highlight that linguistic isolation fact as well. So next slide, I'll pass it over to Rosa to talk about our approach and how in this vast community we make a driven approach.
All right, so now that we have gone over the different linguistic isolations that we face, strategies our team uses has been using for the past couple of years in order for us to be able to reach the amount of people that we have been able to reach, that has been over 1 million. We have been preparing ourselves very well before stepping into the field. The way that we do this, we study, we review these areas before leaving the office. And by doing this, we make sure that the areas that we are visiting, if they are areas that they have high cases of COVID-19, which we call them COVID-19 hotspots. We also visit a lot of areas that are high SVI areas, which just refers to the potential negative effects on communities caused by external stresses or just human health. And also other areas that we are very common with are low vaccination rate areas. And we just prepare ourselves very well. And by reaching them well, we take them the right information that they need. For the areas that we've noticed that they have high cases of COVID-19, we take them information on how to stay safe and also provide to their neighbors, friends, and families. We take them face masks, also help them register whenever it was available to register for at-home testing. And we have even provided them ourselves at-home tests. And for those low vaccination rate areas, we provide them all the current, most up-to-date information we have about the vaccines. We discuss with them even the ingredients that the vaccines have, the different doses that they need, and also provide them with resources. Next slide, please. Addressing vaccine hesitancy. This is something that our team has been, we've been having throughout the years, ever since the vaccines have been released. A lot of people, whenever they were released, they were very happy because they comprehended that it was finally something that was going to protect them from COVID-19 and also help them with that. But others, there was another group of people that they were just hesitant about it. They just felt it wasn't the right approach to get vaccinated for this disease. Just recently, we have been facing this with a lot of people just wondering and having doubts about the bivalent booster, which we're going to be talking a little bit more about it further down the presentation. But we've understood that a lot of people, the reasons that they face these hesitancies, it's not only because of different beliefs that they have, but also because many of them are just not aware that these are being available to them and they're free through our county. A lot of them face governmental mistrust. Also, it's due to religious beliefs and political beliefs. And the groups that we've noticed that are disproportionately low, that have low vaccination rates, are groups of children, Hispanic community, the Black African American community, young adults, and also the East Harris County areas. Next slide, please. The different helpful conversational tools that we've used throughout the years to have these meaningful, beneficial conversations with our communities. We always try to provide them emotional support. We think it's very important that in order for us to be able to understand them and to guide them where they need to be guided, we first need to listen to them. It's very important for us to empathize with them because we just never know the backstories of them. Maybe someone passed away because they believe that they passed away due to the vaccine, which there's a story a little bit more ahead of the presentation that we'll be sharing with you. Others, they just don't have the right information and they are misinformed. And also we take these experiences that we've received from community members to others, because a lot of them can relate with them, and also our personal experience that we have seen in the community and also with our families. And we make sure to partner with communities that are trustworthy, that, for example, that a lot of people see them as credible, like doctors, pastors, because those are people that other people can relate to, and they have their trust. They trust in them. Next slide, please. This image right here is one of our teammates out in the field. Our team, the way that we reach people, we're all over the Harris County area. We go to grocery stores, to churches, to schools, to libraries. We've even been to concerts, because of course we have to be where the community is at, which is everywhere. And again, we make sure to always listen to them, to strive for these deeper conversations. And a lot of people, the way that they feel is if they see that we have a tabling event outside of a grocery store, they automatically think that we're selling something. So we have to approach them and just emphasize to them that the information that we're giving to them, it's completely free. The resources that we're providing to them, it's free, that all of our services are free, and the vaccines, the testings that we are offering to them are also free. Next slide. All right, I'm going to go ahead and pass it on to Mr. Roman. Thank you.
All right, thank you so much. So what we do on a day-to-day basis encompasses really making sure that we're out in the community, talking to people, engaging on a regular basis. So we do this by finding partnerships and leveraging those partnerships to have community events, which could be just having a table or even a wagon going down a food distribution line, and just making sure that, like Rosa said, we're going out of our way to engage with people and talk to them. We also canvass businesses and community centers and libraries and organizations, and just bring this information to them and leave information for their clients or customers to have on hand when they come to those businesses. We also canvass apartment complexes and mobile homes, and as I'll get to in a bit, we have a resource navigation program. So with all that being said, we wanted to share some of our outreach materials here. So we have our COVID care kits that you can see on the right-hand side, and we're continuously updating this material. And to the point at the beginning of the conversation, right, we have to continuously update these materials because the guidance is continuously changing, and we want to make sure that we're taking the latest and greatest information to the community. And we rely heavily on our CHW's feedback to make sure that we're tailoring the resources to the community's needs. As Rosa mentioned, we also take PPE with us into the community, and oftentimes we'll have swag and promotional items, which really helps with our engagement, brings people to our tables if we're in a health fair type of setting, or just at a grocery store or flea market even, so that it can really assist us in starting that conversation as well. So next slide, please. Another way, so this is the back of our care kit, and this has obviously evolved over time. This is one way that we try to simplify all of the changing dosages and age groups and immunocompromised and what's available and when it's available for who. So we've created this chart that is on the back of our care kits that we walk through with our community members to make sure that they understand whether they're a parent or they're an adult or whatever the case is, that they understand when they would be due for a vaccine, they're eligible, when it's recommended to get their boosters. So this is one of the main functions of our group, since we are in the Office of Communications, is to take that really high level information and make it digestible and relatable for our community. So this is just one of the tools that we utilize to do so. So next slide. Really, as Justin talked about as well, addressing the social determinants of health and making sure that we have an overall holistic vision of how we're serving the community is so important. So our team actually creates and manages a host of resources that we don't necessarily have within Harris County Public Health that we can link people to. So this is a postcard that we take with us to all of our events, to all of the activities that we're doing on a day-to-day basis. And you can see the list of resources, over a 40-page document at this point. And we're continuously calling the resources that are on our resource list, making sure that they're still active, still accepting clients, that there's services are still intact, and then making sure that we're connecting our community members to these resources as we're listening to them, as we're hearing their needs and concerns. And a really great tool that our community health workers have employed is starting the conversation with this community resource list. As we've all experienced, people have COVID fatigue, and if the first thing that we bring up to them is COVID-19, we've already lost them, right? So one of the tools that we use is to make sure that they know that we're here to serve them. We are a trusted partner. We go back to many locations that we've been to make sure that they know that we're not just here for a one time, we're really here to support and be that resource for the community. So the community resource list, not just a great tool to help connect people to services, but also a great tool to start engagement for us. So next slide. In 2021, really in 2020, we already understood that the environmental level factors that people were facing in the community were really impacting the decisions and behaviors that they were taking in terms of, leaving work, going to work when ill, not being able to work from home, right? And we created this resource navigation program to really provide application assistance for statewide and local benefits that you can see here. And this has been a really great tool. We've assisted over 2,000 clients with applications to date since launching this program. And then, in terms of engagement, this also allows us to engage around their need and how we can support their needs outside of COVID. And then we use this as a conversation starter. We will schedule appointments with them. But at every chance, we want to make sure then we're also bringing the most consistent and up-to-date COVID guidance for them. So these are not just, we wanted to highlight these, the resource list and our Connect program, not just because of how they address the social determinants of health and the underlying health conditions that people face on a day-to-day basis, but also because it's a great way to engage during COVID fatigue. So we, any other tools and resources that you have as in your work that you can help engage community members, I think that'll be a great tool. So next slide, please. So I'll pass it off to Rosa to talk about our COVID-19 task forces and how we really target our community.
Thank you, Justin. So as we had worked closely with the community throughout the past couple of years, we've understood that we need to cater to them differently because, of course, there's different age groups, there's different, there's a lot of similarities, but there's a lot of difference in them, right? So we created task forces within our team. So the way that we did this, we decided to break down up these groups. We created the superheroes task force with the vision to cater to children from 6 months to 17-year-olds, to young adults, also to the East Harris County area, because we've seen that there was a lot of need there, also to the Hispanic community, the Black African American community, and we decided also to do hidden, which is for the homeless population. And the similarities of all these groups, the way that we work with them is we do presentations and, of course, schools. We do presentations and community centers, and also for Hispanic communities, we go to taquerias, we go to Hispanic churches. For the Black African American community, we set up BDU sites because we noticed that there was a low vaccination rate in this community. So we decided to take vaccines to them to see if maybe the problem was that they were not having access to these vaccines. And also we didn't want to forget about our homeless community. So we decided to also provide them resources, come to them and help them out. And I just wanted to share also a quick story with for the Hispanic community. It has a really special spot in my heart because it has as a Hispanic woman, I relate to them and I understand the different barriers we face in our community. And a few months ago, I was in a community center and I approached this person, this lady, trying to provide her information about the vaccine. At first, she was very rude. She didn't want to know anything about it. But as we conversated, I started to understand the reason why. It's because her father had recently passed away, and she believed that it was due to the vaccine. But as the conversation progressed, she confessed to me that he had only received one vaccine. He decided to leave the country and go to Mexico. He was not protected. He was not wearing a face mask. He was not socially distancing. And whenever we started talking about the different symptoms he was having, we came to the conclusion, okay, he had COVID-19. So that's one of the reasons that we also think that is just very important for us to have these deep conversations with them and just provide them the time that they need, because we need to learn more a little bit about their backstories. Why do they believe this way? And never judge them and empathize with them. And fortunately, by the end, her mindset changed and she told me, you know what, I think I am going to get vaccinated. And I'm also going to get my mother vaccinated because it is true. These resources are being provided to us for free. And we have the answer to be able to end this pandemic. So let me spread that word. But yes, that's the way that we have been working closely with these different groups. Next slide, please. All right, so I'm going to go ahead and pass it on to Mr. Roman.
Thank you. To wrap us up, I know we're at time. Just wanted to highlight, our team and the work that we do every single day. You can see some pictures here. We have a team of 35, including one intern. We have logistics support, great community health workers, team leads like Rosa, and program coordinators. Over the last 2.5 years, we've distributed over 300,000 care kits. We've made over 51,000 outgoing calls to inform our community on where the vaccine or testing sites are nearest them. We've attended over 1,700 events, canvassed and visited over 3,300 locations, registered 562 people directly to for the vaccine, and given out over 200,000 door hangers and reached almost 1.9 million people through the hard work of our community health workers. So we hope this has been informative for everybody, and thank you for this opportunity.
Yes, thank you to all of our presenters. I think we all can agree that was such great information, and also the addition of resources and strategies. Thank you all for sharing. I know we are almost at time. I'm leaning to Sherry, if we want to take a couple of questions. I do know that our team has been active in the chat, responding to your questions in regards to terminology, and in addition to the resources which will be available through AMP and also the Envision Equity websites.
Yeah, I think at this time we can ask for people to drop any additional questions to the chat, and we will make sure to get those to you. And as always, you can submit a request in AMP for technical assistance if you're a CCR 2109 recipient. And we can probably move forward with the polls and our closing slides.
Awesome.
Thank you.
Thank you so much, Sherry. Awesome. So you do see the poll which has popped up on our screen. Before you close out, we do encourage you to complete the poll. This information is so helpful as we plan ongoing training and webinar opportunities for you all. And So we'll take a few moments for that. As a reminder, as you've seen and I've mentioned before, the presentations, materials, and resources referenced today, it will be available in both English and Spanish through AMP and also at the newly launched envisionequity.org. So we encourage you to see that as well. We will also post information on our upcoming webinar in the chat. And so feel free to join us again for our next webinar. Thank you